Hello, this is Dr. Wendy Wood, and I'll be recording a lecture on vascular ulcers. So, we're talking about venous insufficiency or venous stasis ulcers, arterial insufficiency ulcers, and ones that are mixed. That would comprise about 15 to 25%, the mixed ulcers. So, what does it look like? First of all, this is hemosiderin staining that you're looking at, and that is something that we quite often see in venous ulcers. And also alligator skin. This is leptoderatosclerosis. So it's kind of a thickened skin. With venous insufficiency, the prevalence of chronic venous insufficiency ulcers is about 9.4%. 70 to 90% of leg ulcers are due to venous insufficiency, and women have 3 times greater risk. The risk of venous insufficiency ulcers is 7.5 times greater after the age of 65, and the reoccurrence rate is 13 to 81%, and reoccurrence is correlated with non-adherence. So, a little review of venous insufficiency. The venous system is a low pressure system and stores about 70 to 80% of the total blood volume. The deep veins, the femoral, popliteal, tibial, carry 80 to 90% of blood back to the heart. The superficial veins are the greater and lesser saphenous. They drain the skin and subcutaneous tissues and assist with temperature regulation. The perforating veins connect the deep and the superficial veins. So here's a look at the venous system and the veins that we had talked about. We also want to look at that kind of a little more in depth, noticing that the veins have valves, which is very important. In the venous system, again, it's a low pressure system, 15 millimeters of mercury. Static standing increases the downward pressure to about 90 millimeters of mercury. Proximal flow of venous blood relies on the respiratory pump, the calf muscle pump, and competent valves. The etiology of venous insufficiency, sustained venous hypertension. Common causes are vein dysfunction and calf muscle pump failure. There's a fibrin cuff theory we'll talk about, white blood cell trapping, and likely it's a combination of both theories reducing oxygen to the skin. So looking at venous incompetence, again, you have a retrograde venous flow, venous distension, and then venous hypertension. So it's kind of a vicious circle. Some of the risk factors, one, venous hypertension, valve damage, degeneration, scarring, inflammation, clots, or varicosity, varicose veins. Genetic disposition. Calf pump failure could be due to calf weakness or paralysis, decreased dorsiflexion, prolonged standing, or incompetent valves. Benign trauma to the venous insufficient leg may result in ulceration too, due to the edema-induced local tissue hypoxia. Physical therapy tests and measures. There's an assessment for DVT, the Wells assessment, greater than 3, important to get an ultrasound. So you should be familiar with the Wells assessment. Homan sign has a very low sensitivity and specificity, so a venogram is a gold standard. It's expensive and invasive. Ultrasonography is sensitive, specific, and non-invasive, but it's very expensive just for screening. Ankle brachial index, venous filling time, and Trendelenburg test. The clinical assignment for deep vein thrombosis, what you're looking at here is the Wells the Wells assessment. So again, a score of 3 or more would indicate referral for sonogram. This is a very important assessment that you should be aware of. Doppler ultrasound is the gold standard. It's more subjective than arterial Doppler, and it's a resting test, it's an augmentation test, and a reflex test. Indications are to differentiate normal venous flow from incompetent or obstruction, basically to rule out a DVT. The ankle brachial index is comparison of the brachial index and with, you're going to use a sphygmometer or a blood pressure cuff. And normal would be 1 to 1. If it is less than 0.7, then that is problematic. It could be due to a lower leg ulcer or arterial or venous insufficiency. A contraindication to this test would be a suspected DVT. Venous filling time, that's a predictor for arterial insufficiency. The patient's going to be supine, and you're going to look at the superficial veins on the dorsal foot. Elevate the limb 60 degrees for 1 minute or until the veins are drained by gravity, and then lower limb to a dependent position and note the time for veins to refill. Record the time it takes for superficial veins to refill. 5 to 15 seconds is normal. Faster refill time suggests venous insufficiency. 20 seconds or more could suggest arterial insufficiency. Here's a classification system. C0 would be asymptomatic. C1 would be spider veins less than 3 millimeters. C2 is varicose veins greater than or equal to 3 millimeters. C3, leg edema. C4, skin and subcutaneous tissue damage, hemosiderin deposits, or lipodermosclerosis. It's a mouthful there. C5 is a healed venous ulcer, and C6 is a current venous ulcer. Here is a picture of a venous ulcer in the medial malleoli. You can see it's kind of shallow. Prognosis for venous insufficiency ulcer healing. Healing time for full thickness venous ulcers with appropriate interventions. Average is 8 weeks. Smaller ulcers 5 to 7, larger 10 to 16. So integrated interventions. You want to treat the wound, control the inflammation and infection, absorb the drainage, and do debridement. You do want to treat the cause. So if that is venous hypertension, you may need compression and surgery. You would also treat the peri-wound area of moisture, infection control, absorb the drainage, and debride. Patient education is very important, and the healthcare team and patient to address comorbidities. Physical agents and mechanical modalities. Compression parameters we're going to look at. Physical agents, some contraindications to compression, ABI less than 0.7. Acute infection, pulmonary edema, uncontrolled or severe congestive failure. Don't want to do that. Active DVT or claustrophobia, and that's a relative contraindication. Types of compression, a paste bandage, short stretch compression bandage, multi-layer compression, circ aid, tubular bandages, compression garments, and vasopneumatic compression devices. So those compression devices we're probably familiar with. Seen similar things when patients after surgery. Compression garments are used for long-term management, and there's off-the-shelf and custom ones. Knee-high are generally sufficient, and most garments range from 20 to 55 millimeters of mercury. You want to use the lowest effective level of compression possible, and anti-embolus stockings should be used only for non-ambulatory patients. So here's a look at some of those. These are some off-the-shelves. So compression level depends on the class. So of course, lower compression is needed for non-ambulatory patients or patients with class 0. So you would go all the way up to greater than 50 millimeters of mercury for severe venous insufficiency. Now we're going to switch over and look at arterial insufficiency ulcers and what they look like. So you can see some gangrene here. Looking at the capillary system, or I'm sorry, we're looking at the arterial system. So just as an overview, you have the tunica externa. It's a protective outer layer. It's connective tissue, supports the vessel walls. The tunica media, the middle layer, smooth muscle, modulates the vessel diameter. And then the intimal layer, it's a single layer of endothelial cells in direct contact with blood. It's fragile and it's easily traumatized. So you can see those layers here in the picture. So the arterial system overview, there are muscular arteries, which are distributing arteries, arterioles, which are supplied by sympathetic vasoconstriction, and then capillaries. So that's a single layer of endothelial cells about 1 millimeter long. In the arterial system, the pressure is higher, 90 to 100 millimeters in the larger vessels and 25 to 35 as it passes through capillary and 0 as it returns to the right atrium. Oxygen and nutrients flow via the capillaries from the blood to the tissues. Carbon dioxide and metabolic weights diffuse in the opposite direction, and oxygen and nutrients flow via capillaries from the blood to the tissues. Carbon dioxide and metabolic waste diffuse in the opposite direction. Let's look at the etiology of arterial insufficiency ulcers. Some of the causes. First of all, the arterial ulcers are caused by a decrease in arterial blood supply. So some of the root causes of those are trauma, acute embolism, diabetes, rheumatoid arthritis, and Buerger's disease, as well as arterial sclerosis. About 8 to 12 million Americans are affected by this. Arterial sclerosis is a thickening or hardening of the artery wall. Atherosclerosis is a systemic degenerative process where the arterial lumen is gradually and progressively encroached upon. So diet is very important, and looking at HDLs and ADLs, those carry cholesterol. High LDLs enhance cholesterol deposition, and HDLs serve a protective function. Lithium, calcium deposits, and scar tissue accumulate on the intimal layer, causing progressive stenosis. Intermittent claudication is that activity-specific discomfort to local ischemia. Pain usually stops 1 to 5 minutes after ceasing the provocative activity. Think of people walking. Patients generally describe this as cramping, burning, or fatigue, and the pain location is usually distal to the site of occlusion. About 50% of stenosis have had claudication. Etiology of arterial insufficiency. ischemic rest pain, burning pain exacerbated with elevation and relieved by dependency, whereas with venous insufficiency, it's usually opposite. It's worse with dependency. About 70% of with those with arterial stenosis tend to have ischemic resting pain. Arterial insufficiency, ischemic ulcers are more likely. With arterial insufficiency ulcers, you could see ulceration and gangrene due to oxygen requirements not being met. It's most commonly due to trauma in an ischemic limb, but it can be spontaneous and comprises about 5 to 10% of all lower extremity ulcers. So the progression of atherosclerotic pain usually starts with arterial insufficiency, intermittent claudication, ischemic rest pain, and then ulcer. Here's a patient with a gangrenous toe. You can see how black it is. There's many different factors that can lead to arterial insufficiency: hypertension, trauma, advanced age, diabetes, smoking, and hyperlipidemia. Some of the PT test and measures: pulses, Doppler ultrasound, the ABI index, rubric of dependency, and venous filling time. So with pulses, you want to check pulses bilaterally, and bifurcation of the common femoral artery is a common site of occlusion. You want to grade between 0 and 3 plus. That tends to be unreliable, though. The posterior tibial artery is the main foot blood supply. The dorsalis pedis dorsal is the dorsal foot blood supply. The absence of a palpable pulse should be followed up with a more sensitive test. Doppler ultrasound is handheld, and it's a probe. It has an audible signal over the moving fluid, and it's another method of assessment when pulses are not easy to palpate. Indication for this would be a decreased or absent pulse. The ankle brachial index we talked about before. It's reliable, non-invasive, and sensitive and specific method to diagnose peripheral arterial disease. The local values correlate with increased severity of atherosclerosis and CED, and it's an indicator of healing potential. Some indications to perform this would be decreased or absent pulse, signs or symptoms of arterial insufficiency, or a history of PVD. So here's a look at ankle brachial index. This is using a Doppler ultrasound. And then what you're going to do is you're going to use this sphygmometer around the patient's distal calf, inflate it, and the systolic pressure of the artery is measured and used to calculate the ABI. So basically, it's the systolic pressure of the lower extremity over the systolic pressure of the upper extremity. With interpretation, this is a look at the ABI index. If it's between 1.1 and 1.3, there's actually vessel calcification. 0.9 to 1.1 would be normal. 0.7 to 0.9 is mild to moderate arterial insufficiency. 0.5 to 0.7, moderate arterial insufficiency. Less than 0.5, severe arterial insufficiency and resting pain. And less than 0.3, resting pain and gangrene. Capillary refill, that's a reliable indicator of surface arterial blood flow. You're basically going to push the tip of the toe with enough pressure to blanch the skin and hold for 5 seconds. Normal would be less than 3 seconds. Patients with arterial insufficiency have delayed capillary refill time. Indications to do this would be if there's a digital ulcer or an abnormal Doppler ultrasound. Rubric of dependency is an indirect assessment of lower extremity arterial flow. You're going to have the patient supine, note the plantar foot color, and then elevate the lower extremity for 1 minute. You want to note the foot color. Normal arterial flow is little or no color change. When you return the leg to surface, a note time to return to original color. Normal returns in 15 to 20 seconds. Oops. These are some guidelines here. 45 to 60 seconds is mild, 30 to 45 moderate, and paler within 25 seconds of elevation. It's going to be severe arterial insufficiency. Venous filling time is a predictor for arterial insufficiency, and I think we talked about that previously. Patient's going to be supine, and you're going to note superficial veins in the dorsal foot. Elevate the limb for 1 minute until the veins are drained and lower to dependent position. Note the time for veins to refill. Here again, we talked about this previously. Less than 5 seconds would indicate venous insufficiency. 5 to 15 normal, greater than 20 arterial insufficiency. So here is a look at that, arterial wounds. Prognosis, you got to look at the wound size and depth. More superficial and smaller are going to heal faster. You have to look at tissue perfusion, ABI greater than 0.5 and toe pressure greater than 55 milligrams. There's little research on arterial insufficiency ulcer healing progress. Non-healing ulcers are ones that 20 to 40% decrease in size within 2 to 4 weeks of appropriate interventions. If no signs of healing or decline in status, you need to reassess and make the appropriate referrals. A request for further medical testing, patients with invalid ABIs, wounds that fail to progress. You need a wound culture and sensitivity if you suspect infection, and a bone scan and x-rays if exposed capsule or bone. So that is the end of ulcers. Thank you.